Hello, my name is Ozhan Turan. I am the Director of Fetal Therapy at University of Maryland Medical Center. Today, I'm going to present you a challenging case for treatment of Twin-to-Twin Transfusion Syndrome, which is Proximate cord insertion. This is a placenta of the monochorionic twin. As you see here, on the right, this is donor cord insertion. On the left, recipient cord insertions. All these colors shows the blood vessel distribution. The arrows represents actual anastomosis between donor and recipient causes twin-to-twin transfusion syndrome. The treatment for twin-to-twin transfusion syndrome is all over the world is standardized is laser photocoagulation of the intertwin anastomosis. So how we do that? We go with the scope and burn these anastomotic points and then connect dots between the points and separate both babies on the placental surface, which cause complete dichorionization. This method is also called as Solomon technique in the literature. However, if there is a proximate cord insertion, as you see here, it is very difficult to perform this procedure. As you see on the left and right, all blood vessel connections are very archaic, and it's not possible to identify which blood vessel belongs to which baby. Therefore, we modified a new technique to fix this problem. In most of the experts, they actually define this disease as incurable problem. However, in our series, we were successful to treat this pregnancies and give them a possible good survivals. So this lady came to us at 24 weeks and 3 days with a diagnosis of severe twin-to-twin transfusion syndrome with pulmonary stenosis. The R on the screen represents the findings of recipient and D represents findings of donor. As you see on the top, recipient has pulmonary stenosis, which is a functional problem, maximal vertical pocket of 15, and donor has no fluid. And there was a 32% growth discordance between fetuses. As you see on the screen on the left, this is the two-dimensional view of the closed cord insertions. On the measurements, you see that the difference between both cords was only 6 millimeters, which is a quarter of the inch. On the right of the screen, you see the tri-dimensional appearance of the same image. M represents membrane, D represents donor cord insertion, and the R represents recipient cord insertion. So the diagnosis was proximate cord insertion with stage 3 twin-to-twin transfusion syndrome, and we decided laser photocoagulation under epidural anesthesia. Normally, I perform laser procedures with a regional anesthesia without epidural. However, in this case, we choose the epidural because of the anterior placenta. Again, I want to show you the archaic distribution of the blood vessels on the proximate cord insertion. Let's make it simple for you. This is the same description of the proximate cord insertion. Yellow here represents membrane, D is donor, and R is recipient cord insertion. Let's start again. These are the distribution of the blood vessels from donor. As you see here, one red means that artery and blue represents vein. You see there is an anastomosis in between two blood vessels, but this is not a twin-to-twin transfusion syndrome blood vessel, or doesn't cause the TTTS. However, this is a normal connection of blood vessels which supply a big cotyledon. Similarly, same blood vessel distribution you see on the recipient side. This one on the top, actual real TTTS connection. On the below, it is not. Therefore, it is very important to identify which anastomosis causes TTTS, which is not. If you burn the dots on the image as black, you kill the placenta and the baby. If you burn the yellow ones, is actually you can treat the twin-to-twin transfusion syndrome. And the vascular equator is something like this. What we define in our technique is start at the one edge of the placenta, anastomosis, and find every instant anastomosis and burn them until the center of the cord insertions. So about 1.5 centimeters away of the cord in both sides, we stop cutting and then go opposite side. Start again edge of the placenta, go back to the cord insertions. In this way, we spare all the regular anastomosis, including hernial anastomosis, and we will close all the anastomosis causes twin-to-twin transfusion syndrome. We perform this procedure for this pregnancy as well. As you see in this video, there is a very close cord insertion, and normally a laser procedure takes 25 to 30 minutes at most, but this one is about more than 45 minutes because I have to go back and forth to identify which blood vessel belongs to which baby. And as you see, I try to find the connections between both babies and burn them with the laser. As you see on the top of the image, this is a red, yellow light, which is a laser light. After the procedure, as you see in this slide, post-operative day number 1, pulmonary stenosis start to resolve and completely resolve post-operative day number 3, which actually represents an excellent laser treatment. So it means that we close all the anastomosis without giving up any of them. And the donor's bladder started to be visible at day number 3. We discharged her home, and she came from another state. Therefore, we refer back her to her actual physician. She ruptured her membranes at 31 weeks and 5 days, and 32 weeks and 1 day she had a C-section for abruption. Both babies were alive. After the short NICU course, they went home. They met with all their milestones in the age of 1 and came and visit me. As a summary, proximate cord insertion in twin-to-twin transfusion syndrome is a treatable disease in experienced hands. If you would like to refer a similar patients, we are happy to help you. Our phone and contact numbers on the screen. You can call us from 410-328-3865 or 888-FIX-TWIN, or you can visit our website is umm.edu/CFC. Thank you.